All right, let's just have them in.
Yeah, was that you ready, Shelley?
Yeah, I think we're all ready.
All right, thank you, everyone. I'll call the meeting to order. This is Franco Castro-Marin speaking to you at the PMD meeting at 12 noon on November 17th, 2022. Shelley,
Amber, right?
can you go ahead and
Erin O'Connor.
Present.
Brian Smith.
Present.
Chester Key. Franco Castro-Marin.
present?
Garth Gamer. Heather Miller.
Present.
Jason Johnson.
Here.
Josh Gaither.
Here.
Mark Hansen. Matt Shaw.
Present.
Paul Dabrowski.
Present.
Philip Hannon.
Present.
Shari Brand.
Present.
I count 11. We have quorum. Thank you.
All right, so let's go ahead and start with the chairman's report. We'll review the attendance report along with a friendly reminder that if you miss 2 consecutive meetings, the Bureau will reach out to you and ask if you're still interested in serving on the committee. Right now, there are no vacancies to report. Shelley, if you could show us the 2023 meeting schedule now available online.
All right.
So that is now available for you. Any questions on those items? Hearing none, I'll move on to the Bureau report. Chief Garcia, good morning, good afternoon.
Good afternoon, Dr. Castro-Marin. Some updates. This week is National Crash Responder Week. There's been a proclamation to declare this week Crash Responder Safety Week here in Arizona, acknowledging over 100,000 traffic-related injuries and deaths in Arizona over the last couple of years. We want to remind everyone to move over and slow down when you see flashing lights. And if Adam will help me, we'll drop into the chat the Traffic Incident Management website here in Arizona that offers traffic incident management courses for folks. If you have any questions about those resources or upcoming classes, please reach out to David Harden from the Bureau of EMS. We have some funding updates. The department has identified a small amount of funding to be able to support rural paramedic education across the state. We want to thank our 4 regional councils for helping us to develop plans to distribute and award those funds across the state with the goal of increasing the EMS workforce here in Arizona. We've seen the state invest significant funding in nursing education in the last year to combat staffing shortages, and we recognize that we need to begin to look at funding for EMS education as well to maintain our EMS workforce here. On the IT side, we have a few updates to share with this committee. You all, I think, have heard us talk about our new EMS portal. We are working on updating our EMS portal and launching it in 2023. And so we will be coming back to committee meetings in the beginning of 2023 to share some updates and demos of the new features that will be available in the new year. We've also recently launched a new 911 dashboard. Adam, if you'll help me drop that link in the chat as well. We'll be doing a blog on the new EMS dashboard that highlights the statewide calls that EMS providers go on a regular basis. It is close to real-time data and shows a weekly snapshot of our EMS system statewide. There are also some other features on the dashboard, and we invite you to look through it and let us know if you have any feedback. We will be sending out a blog on that next week. Also, a big thanks to Ann Bosbrink and Avondale Fire, who have taken us live with BEMSTS version 3.5 reporting. I think that all of our providers that report to AZ Peers know that BEMSTS version 3.5 is coming, and we need to get all of our providers online with the new version by July 1st. And we are proud to be one of the first states that are now accepting BEMSTS version 3.5. If you have any questions, please reach out to Ann. Finally, we have some rule updates. In the last time since we've met here as a PMB committee, we've had an EMS scope of practice update that became effective on September 22nd. And we have the updated table 5.1 scope of practice table available on our website. There's also been an air ambulance staffing rule update that became effective on November 8th. Finally, to round out our updates here, wanted to share just a bit about some of our preparedness planning at the Department of Health Services, working closely with stakeholders. We are looking closely at the number of RSV and flu cases, especially this time of year. We're seeing a significant increase in pediatric cases for both RSV and flu. And we're working closely with our healthcare coalition and other stakeholders to continue to monitor our surge capabilities. If you have any questions on the pediatric side, again, we have Adam Rodriguez here with us today. He is our EMS for Children coordinator. And so please reach out to him if you have any questions or are seeking resources along those lines. Secondly, on the agenda here, we have an update on Arizona's infectious disease of high consequence plan. The last update to that plan has been in the last several years. And so it is now time for us to begin to look at our Ebola patient assessment and transport guidelines here in the state. As a region, Region 9, which has one Ebola treatment hospital in LA at Cedars-Sinai. We have been talking with our regional partners, and they are doing the same and updating all their plans for infectious disease of high consequence. We're looking closely at what LA County has done with respect to patient assessment and transport guidelines, and hoping to be able to work closely with all of our stakeholders here to see if we can dust that plan off and implement something similar to what we've seen in other areas like LA County and other nearby states. Certainly we'll have some work to do and communication out with all of our hospitals at this time, since all of the hospitals here in Arizona are now considered frontline hospitals if we were to respond to an infectious disease of high consequence like Ebola. And you know, at this time we don't have an updated plan to share. Like I said, we'll be working closely with our local public health partners and all of the hospital and frontline EMS stakeholders on any potential updates in the future. I think the biggest thing that we want to emphasize here as we work on updating many of our preparedness plans is, at this time, we do not have any suspect cases. There are no persons under investigation or any increased new threats related to Ebola in the state of Arizona. If that changes, certainly we will make sure that we are communicating that out to all of our frontline providers that we work closely with. And I think that that's all I have at this time, unless Dr. Bradley, you'd like to add anything to that?
I think just the two pieces to add. As of right now, because there are no kind of suspect cases in Arizona, we are not sharing widely the messaging from CDC regarding dispatch screening. We felt with discussions with our dispatch centers across Arizona that at this point in time, dispatch screening would kind of delay response times for the majority of our calls without there being a true benefit. However, if something were to change, we have started that communication process with them. I think the other largest update is for everyone who is working in a hospital. The big change now compared to our prior Ebola kind of preparedness activities is we no longer have any assessment hospitals in Arizona. So in the past, we had 2 assessment hospitals that theoretically would be where patients would go. So the definition of a frontline hospital is well defined. If you would like to Google that, CDC frontline hospital for Ebola, but essentially means from an EMS perspective and a hospital perspective, any patient that is a potential risk would go to the closest facility and then would have to potentially be transferred out of state for any further evaluation. So we just want to make sure that that communication is really clear. That's probably the biggest change now compared to the last time we put out some Ebola guidance to preparedness activities.
Yeah. So I think that just underscores that we have a lot of work to do here in terms of planning and communication on any future plan updates. Certainly, we will be coming back to groups like PMD to share additional information as we receive updates from both CDC and NETEC on recommendations for EMS and frontline hospitals. I'm going to transition really quickly to introducing some new Bureau staff. In the room today, we have Russ Lindholm, going from left to right. Russ Lindholm is our newest EMS regional coordinator for the Western region. Next to him is Stephen Ferris, EMS regional coordinator primarily for the Central region. And then going all the way around the room, we have Brian Hubble, our new CON and rates manager. To round that out, virtually we have Jeff Kerr, compliance and enforcement manager. And we are just excited to be able to introduce these members of the Bureau to everybody. They have tremendous EMS backgrounds and will be great resources to the community. Please join me in welcoming them. And then Dr. Bradley, back to you.
Thank you. So I will just briefly mention the naloxone leave behind program. We have talked about this previously at this committee. The Bureau was awarded the FR Care grant for an additional 4 years. This grant went live October 1st, so we are currently in the build-out phase of the grant. This time around, we really are focusing more attention on EMS agency naloxone leave behind program. So we really will have quite a bit more resources coming out. Julia Vinton is the current lead for that. And so as we develop some more of the resources and get things prepped to go, we will do a large outreach statewide for EMS. We just wanted to let everyone know we did receive an additional grant for 4 more years that went effective October 1st. Thank you. Back to you,
All
Dr.
right, so
Castro.
thank you very much. Yeah, thank you very much, everyone. So let's go ahead and move on to our discussion and action items. Item A is discuss, amend, and approve the draft minutes from July 21st. Can I get a motion?
So moved, Brian.
Thank you. Can I get a second?
Seconded, Philip.
Thank you,
Thank
Philip.
you, Philip. All right, hearing none. All those in favor of approving the minutes, say aye.
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 Any opposed? Any abstentions? All right, the motion carries and the minutes are approved as shown. Item B, discuss, amend, and approve draft minutes from special meeting dated August 30th. Can I get a motion, please?
So moved, Brian.
Thank you, Brian.
Seconded.
Can I get a second?
I second.
Seconded, Philip.
Any discussion or are any amendments needed?
Wait, sorry, who was the second?
I believe that was Dr. Dabrowski.
Oh,
Dabrowski.
thank you.
Thank
Sorry.
you.
No further discussion or need for amendment. The motion carries and the minutes are approved as shown. Item C, this is a standing agenda item to discuss any topics anyone wishes to bring forward as they pertain to hospital-based paramedic practice. I know that we have some items later on in the agenda for specific approval. All right, hearing none, we'll move on to item D, discuss, amend, and approve making diltiazem required instead of optional on table 1, the EMCT drug box.
Hi,
Can I
this
get,
is
yeah, go ahead.
No, it was Sandy. I just, I brought this forward quite a long time ago. I'd almost forgotten that I had asked for it to be on the agenda. Do you want me to tell you my thoughts?
Yeah, that'd be great, Sandy, if you
Okay.
could.
Yes, thank you, Dr. Castro-Marin. It's listed as an optional, but I wondered if perhaps that was not a mistake, or if we could look at that again, because of course right now there's a shortage of it, so I guess it doesn't really matter a whole lot, but it's in most of the drug boxes and the medics do use it. So instead of it being an optional, I just wondered if it shouldn't be a required.
I have a question to the group, or specifically Dr. Bradley. If you recall, if this was changed to optional within the past several years because of ongoing shortage issues?
I don't recall. Sorry, that was mine. I don't recall the rationale when this was changed. It's been some time. We could go back and look at the minutes for when the change was made. I know at one point we did have the option of diltiazem or verapamil, but once verapamil was removed, this remains the only optional agent for this.
Does anyone else have any comments? So my only comment on this, and I've brought this up in a couple of different forums, you know, I'm not convinced that diltiazem actually adds anything in terms of patient-centered outcome improvements, such as survival or decreased hospitalization or anything like that. I've actually been informally checking in with the other emergency providers at my facility, and I may actually start doing a case review on pre-hospital diltiazem. But I did do a literature search going back about 15 years to try to understand where this really came from in terms of pre-hospital usage. A lot of the studies that are published out there are basically feasibility studies that really don't look at patient-centered outcomes, but rather vital sign outcomes like average heart rates and things like that. And they looked at the feasibility in terms of general safety. But really nothing in the past 15 years that I saw that really make a difference on patient outcomes. And there's a lot that, there's other published reports that really would advocate more of a supportive care approach in the pre-hospital environment rather than aggressively treating, trying to achieve rate control in the pre-hospital setting. Anecdotally, I personally and several of my colleagues have mentioned cases where pre-hospital administration of diltiazem has actually worsened a specific patient outcome, such as when a pre-hospital provider seeks to achieve rate control in the pre-hospital environment, when in fact the patient's AFib is a compensatory mechanism, such as a patient in shock who needs that tachycardia, especially in the elderly. And so based on my initial looks at this, I'd personally advocate that diltiazem remain as optional. It is on shortage very frequently. There's a question about whether it really makes a positive difference for patients in the pre-hospital environment. And honestly, I'm looking at moving it from the drug box, but at this point, I'd probably prefer that it stay optional myself.
So I'll add in my 2 cents. I think it's important to have an AV nodal blocking agent available. I think there are many cases in which we're all familiar with that some education or additional training and could be helpful. But I would advocate strongly for the presence of an AV nodal blocking agent should be available in the pre-hospital setting. Whether that's diltiazem or metoprolol or verapamil, I get that reason for it being optional. But I would advocate for the presence of, in this case, since DILT is our only AV nodal blocking agent, some DILT in drug boxes.
Any other comments on this item? All right, so I guess the motion on the
Bronco, sorry, one more. I unmuted my computer and then accidentally muted it too quick. Dr. Rice had a comment.
I don't have much more to say other than just to make sure that I support that we keep diltiazem available or as Josh said, something available that agencies can use for that purpose. So.
Thank you. So I guess we'll propose a motion on the floor here, which is to approve. The motion on the floor is to approve making diltiazem required instead of optional. Is there a specific motion on that request, or perhaps an amended motion?
Yeah, I don't have any known members making a motion for this.
Sandy, would you like to make a specific motion on this regard, or keep as is?
I don't think she's a
I
voting member.
I can't make a motion. I'm not part of the committee.
Oh, excuse me. I'm sorry. My apologies. So do we have any motion? Am I hearing any motion to put this to a vote?
Yeah, I don't have any.
So hearing none. Got it. So hearing none, Shelley, we'll go ahead and move on to item E. Item E is, yeah, go ahead.
Yeah, I'm going to write down no motion made on this item. And then next is E.
A member bringing forward drug profiles for ibuprofen and acetaminophen.
I think the background on this one is someone had requested that we add drug profiles for those two agents, and so we're just looking for a member of the committee to put those together if they do want it added to our current drug profiles.
Brian will do it.
Thank you, Brian.
Thank you, Brian. Appreciate it. And so we'll await that information from Brian in a future meeting. That will be a drug profile draft for ibuprofen and acetaminophen. Item F, discuss, amend, and approve forming a work group to review and potentially expand drug table 3, which is titled Special Agents Eligible for Administration and Monitoring for Paramedics in a Hospital Setting, to add oral narcotics such as hydromorphone, medications such as haloperidol, droperidol, metoclopramide, other antiemetics, vasopressors, narcotic drips, propofol, and Presidex. Sandy, did you want to add some background on this?
Hi there. This is actually Dr. Beth Ranney. I work with Sandy Nargard. I'm over at Banner, Ironwood, and Goldfield. I apologize for taking up everybody's time, but we would actually like to come back at a future date to discuss this. We do have some more work to do before we can gain consensus. So I apologize that we asked to be on this this meeting. We need more time.
No problem. So we'll go ahead and table. We'll revisit in the future.
But Franco, isn't it just to set up a work group though?
Yes, yeah, you're right. That's the thanks for pointing that out. So
right, because
it looks like the yeah.
My thought is this is something I'm also highly interested in for our hospital-based paramedics. So I know that they're not ready, but I think it's actually a good idea to put together a work group so a bunch of us can get together and get started before it's actually presented to PMD.
Okay, and this is Jason?
Yeah, sorry, yeah.
Would you like to make a motion?
Yeah, I'd motion for that.
Okay, can I get a second?
I'll second that. This is Matt.
Matt, thank you. So the motion on the floor is to form a work group to review and potentially expand drug table 3, as I mentioned. Any further discussion?
So I'll just add to the discussion piece. As we look to form this, historically we've brought individual drugs kind of one at a time for discussion. So that would be something we do as the work group, is to kind of line item each medication separately. That's historically what we have done when we've added things to the drug table. So just to make sure that, otherwise it gets a little complicated when we're making motions and voting on an item if we have too many lumped together. I do see Josh, Dr. Gator, I believe that you have your hand up as well. You're muted if you're talking, Josh.
Man, technically challenged. My apologies. I support a work group. It's never bad to work through things. As I look at this list, though, I want to voice a concern as we go into that discussion. It looks like we're very much crossing some fairly well-established lines in paramedic training. Right, we have a community paramedic that would do home health care. There's an established training curriculum. There's an established national exam. Those community paramedics would potentially give oral narcotics, that type of stuff. We also have a critical care paramedic curriculum. Again, standardized curriculum, standardized exams. And through that training curriculum and exams, you would learn about propofol and how to titrate it. I'm wondering if we are not way overstepping our kind of traditional training in creating a catch-all hospital paramedic list that essentially lets a paramedic with no specific training give an unlimited drug list. I see this as very, very, very room for us to put our paramedics in a really bad spot. I'm worried about the slippery slope here. So that said, if it's a work group, we're not voting on anything but the work group. That's totally cool with me.
Yeah, this is Matt. I would have to agree with that. I'm agreed to the work group because I'm curious kind of where the goal for this is heading. And if it's just transporting patients who are on a propofol drip, for example, from the ED to the ICU because of a shortage of nursing, then maybe that makes sense. But I would just be nervous that all of a sudden paramedics are being asked to manage these patients during nursing shortages, and this is quite a large jump.
And this is Gail. Two things I'll add just for those of the PMD members that were not on the Education Committee meeting. The Bureau is starting to conduct a survey looking for kind of recommendations and what people are looking for a community paramedicine and critical care paramedicine endorsement on top of kind of the current certification. And so that is part of what that is looking for, is this type of feedback. What are things that you would see or you would want to have kind of available for training for those two entities? So we do look to send that survey link out widely. We'd definitely make sure that PMD and MBC members get that survey link. I think that is an important part of the conversation. I do want to remind members as well, once we do approve a drug at the state level, it's on the drug table, so it doesn't specify for how long the patient, that's going to be used for transporting a patient within the hospital briefly. Once it's approved, it could be used potentially for a 12-hour shift monitoring. So just want to remind the members as we do look at things like this and approved medications that we can't specify time frames. I want to make sure I mention that.
Any other comments?
Yeah, and this is Jason, and that's kind of what I was thinking about doing this work group offline, is we can kind of clarify what all this is before we actually bring it to PMD, kind of hash it out, like, do we even want any of these as for hospital-based, and kind of do all that clarification instead of just having something that's brought to us in bulk.
Understood. Josh, do you have another comment?
I just was hoping for a little more of a timeline on the results of that survey Dr. Bradley missed, and maybe my thought process here is, if we are going to look at potentially developing a critical care paramedic scope and a community paramedic scope and a hospital scope, is this a motion that we need to table until we have that direction from the DHS? So any timeline on that, Dr. Bradley?
I will defer to Rachel on that one.
Yeah, we don't have a hard timeline since we haven't opened up officially. We have not opened up rulemaking in this regard. So we don't have a definitive timeline here, but certainly we'd love to take through the end of this calendar year to get feedback on that survey that was discussed in the last meeting. And from there, we can look at a potential timeline if we were to move forward with the rulemaking.
So, yeah, I think that's a really good point, Josh. So, you know, I don't know how I would change that. So can I change my motion to table it till next time? So then when we meet in March, maybe we'll have a little bit better idea of whether it's even worth going forward or doing it separately.
Yeah, so Shelley, would it be best to go ahead and remove the motion and then table this item?
I do see Dr. Rice has her hand up as well, still, if you don't mind calling on her.
Raise your hand.
Oh, yeah.
Sure, Dr. Rice, another question or comment?
No, only if we were not if we're going to table this, then it's completely irrelevant. I was only going to make the comment that until we have some clarity from the DHS, I would suggest that the work group not move forward on drugs that would be in the critical care nature, just out of the sake of everyone's time, and not spending the time going through those medications. But if we're tabling this, then it doesn't really matter.
Yeah, so you can withdraw your motion.
Yeah.
Or amend it to say motion to table.
Yeah, so I'll amend it to say tabling it till next meeting.
Is there a second?
All right.
Matt, do you want to second that?
Yep, I second that.
Okay. And then a vote to table.
Okay. Can I get a vote? All those in favor of tabling a motion to approve a work group to expand drug table 3, all those to approve tabling this motion, say aye.
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 Any opposed to tabling this motion? Any abstentions? All right, so the motion is tabled. We'll go on to item G, discuss, amend, and approve edits to table 1, the EMCT drug box to show dexamethasone or solumedrol on one line, optional and authorized for the EMT I-99 and paramedic as well. So this is an item that I wanted to bring forward. The thought here being to add, since a steroid is already approved, a specific steroid is already approved for appropriate indications, my hope was to add simply medication of the same class, either of them being optional, with a focus on hospital-based paramedics. But my thought process there is that this wouldn't be too much of a training or curriculum stretch since they are in a similar drug class. Can I get a motion on the floor for this item?
I'll make a motion, Brian.
Thanks, Brian. Can I get a second?
Sorry, I'll second it.
Thank you. So as far as discussion goes, that's the case that I have. I don't really have any other contributing factors. It's really just with an eye towards allowing some additional bandwidth for the hospital-based paramedic.
Hi, it's Erin O'Connor. I just had a question in regards to why the solumedrol brand name is used over the generic.
Oh yeah, so it's no intention there. We can certainly change to the generic, and in fact, that Shelley, I'm not sure if it matters, but I have another action item we can probably fold into this one with an amendment, which is to remove the sodium succinate qualifier alone, which Aaron, if I'm not mistaken, will at least allow the breadth of using oral versus IV formulations.
Yeah, I'm sorry. So you were saying, I think you cut out there a little bit, or I missed that. You're removing the sodium succinate part of it. Is that what you're saying? And
I'd like to propose that we remove the sodium succinate qualifier so that this will capture the oral formulation as well.
okay, so removing solumedrol, the brand name, and just leaving it as methylprednisolone, period, and give the dose of 125.
Correct.
Okay, got it.
Correct.
Hi, it's Brian.
Go ahead, Brian.
I don't understand actually what it is that you're trying to do. Right now, methylprednisolone is required, dexamethasone is optional. The way this has it here is to have another line with dexamethasone or methylprednisolone, and they're both optional, but I don't see, is it your intent to really have methylprednisolone being required in the box and dexamethasone is optional, and then having another line because basically you've made the way you have this in here for the proposed is they both become optional, so you wouldn't have to have either. So you could change to the way we have the benzodiazepines, Ativan or lorazepam, lorazepam, midazolam, and diazepam with ORs. You could just delete the line methylprednisolone and change it to a line that says dexamethasone or methylprednisolone. You don't make either one of them optional. You can carry one or both of them if you want under that kind of classification. And it doesn't matter. They can use it in the hospital because it's in the scope of practice. If that's what if you want to be able to carry either one of them and not have to carry methylprednisolone, that would be, I think, the ultimate way to handle it the way we've done the other ones.
Yeah, I think my only, and it's been a while since I submitted this request, but I think the biggest request that I had was the one listed in item H, which is the sodium succinate qualifier, so that the drug box will show methylprednisolone and allow the breadth of either having the IV or the oral within scope.
So I think there are two separate action items, so we do need to kind of handle them separately. You can certainly amend the motion for G to specify instead of Solumedrol brand name, the generic, but we do need to keep those two items separate. They're on the agenda separately.
Okay. Yeah. So for right now, the motion on the floor is to we can make an amendment to remove the trade name Solumedrol and switch that to methylprednisolone. So that is a friendly amendment I will make here. And I will also add the detail mentioned by Brian, which is to have them as or and remove optional.
So if this is Matt, if that was the case, then we would essentially remove the line for dexamethasone and methylprednisolone individually and combine them to your new proposed style. Is that correct?
That would be
yes.
Okay.
And then just for clarification, we're removing optional.
Right, word optional.
Okay.
And then if we just delete.
So in summary, go ahead, Brian.
And then if we just delete the dexamethasone and methylprednisolone, it resolves having to even deal with the sodium succinate issue later on.
Yeah. So in summary, the list will show dexamethasone 8 milligrams, followed by methylprednisolone, no qualifier, 125 milligrams, and in between them, we'll have the word or. Does that summarize, Brian, accurately?
Yes, that would be my amendment.
Okay. Any other discussion? All right, so all those in favor of approving the edits to show dexamethasone 8 milligrams, followed by or, followed by methylprednisolone 125 milligrams, with the words optional removed and with the qualifier sodium succinate removed, All those in favor, say aye.
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 Any opposed?
There is a question
Any
in the chat.
abstention? Oh, sorry, I don't have my chat up. So the 8 milligram, I can't answer that specifically, why only 8 milligrams of dexamethasone. That is the optional minimum. It's a minimum supply. And so you're always free to carry supplies higher than that, but the par value is 8 milligram minimum. So carrying on with the vote, any abstentions? All right, the motion carries. Thank you everyone, and thanks Brian for your help getting through that. I will then remove item H, which is to vote to remove the sodium succinate modifier. The next one is item I, discuss, amend, and approve recommendations to table 5.1 on the scope of practice skills, and the request is to add intraosseous access placement as an STR skill for the EMT level of scope of practice. May I have a motion to discuss?
So moved, Jason.
May I have a second?
Second, Dabrowski.
Thank you. So this is my request as well to the board. Basically, as many of you know, especially for cardiac arrest, there is at least a non-inferiority in terms of success and speed of placing intraosseous lines as your first choice for access under those cases. More and more for those kind of time-sensitive illness and injury entities, we are asking EMTs to work at top of license for this, including making supraglottic airway an STR for that skill level. I think that allowing the EMT scope of practice to include IO placement will benefit, especially with pit crew style cardiac arrest resuscitations, et cetera, to allow the EMT to perform that procedure, which is relatively easy to train and common enough that skills can remain sharp. And so wanted to look at adding that as an EMT skill to further enhance the contribution of the EMT, as well as free up the paramedics to go on to other skills and tasks, especially in high profile and high intensity call types. I think contextually, it's also a good fit in the sense that EMTs also can place peripheral IVs as an STR as well. And to me, this strikes as a easier skill with a reasonably equivalent, if not superior, safety profile.
Dr. Castro-Marin, I just have a question. Are you going to have this in conjunction with the STR for IV starts so that the EMT would have to have that STR before they had the EZ-IO? Just a question.
Sandy, if I understand your question, would I have any specific stipulations in terms of how an EMT can achieve the STR and whether or not that would bleed over into previous training for IV? I have no specific preference for that. I would defer that up to perhaps either education or the Bureau if they have any precedents for any sort of thing like that. My sense is that it wouldn't make sense to require that an EMT achieve the STR training for IV as a prerequisite. It seems like an STR for IO placement can stand on its own merits.
Hey, Franco, it's Amber.
Yeah, go ahead.
Can you hear me? I think that when I when we compare our scope of practice with national scope, and we've tried to align as well as possible to national scope of practice. Currently, IOs would not be listed in the scope of practice for EMTs. And I'm not sure that I'm concerned that the data that we looking at success rates and looking at complications is mainly from paramedics placing IOs, not from EMTs placing IOs. So I would just be extremely cautious in this. And I don't know that this is something I would necessarily favor.
Thank you.
Hi, it's Brian.
Any other comments? Yeah, go ahead, Brian.
I'm a bit concerned about this because I understand perhaps the interest in having EMTs when they're working with paramedics to be able to do this for cardiac arrest. But once you do this, that doesn't limit it. And there are EMTs out there with IV skills who are not necessarily working with paramedics, who may be initiating these. It will be up to a medical director how that occurs, but if they do that outside of being associated with an ALS crew, what value is it to do this? And then in patients who have the ability to feel pain, even if they're critical, if they're not in cardiac arrest, that visceral pain associated with infusing fluids through an IO is really, really significant. And now you may have the option of EMTs putting in IOs in patients who can feel pain and they have no ability to be able to resolve that situation. So.
All right, good points. Any other discussion? Well, based on the comments from Dr. Rice, specifically as it, yeah.
There was just a question in the room, just to clarify, Dr. Johnson had asked, we do not currently have the ability to open scope of practice. We just had an update to that. So he just wanted me to clarify that because he was not sure that everyone online heard. So currently scope of practice is not open for update, but we always do take recommendations from both this committee and MDC if there are recommendations to make changes. So he just wanted to make sure that was heard by the whole committee.
Well, I think that I'm compelled most by the comments made by Dr. Rice in terms of trying to stay aligned with national scope of practice. And if this represents a deviation from that, then that's for me personally, a higher priority is to maintain that alignment. And so I'll go ahead and withdraw the motion. So we'll move on to item J, discuss options for T3G updates. Is there someone leading that up?
Sure, this is Gail. So I wanted to just kind of bring up some options to talk about how we can do this process. So this committee has worked very hard to have a number of extra meetings to try to tackle the entire TTTGs. I think those of you who were involved in the first two updates recognize that it took almost 2 years from start to finish through the PMD and MDC cycle. What we saw at the last MDC meeting was quite a bit of feedback of, even from some members who were present at PMD and have been so long between when they had actually approved it and then it came to MDC, and we had essentially almost most of the work is coming back to this committee to review. One suggestion from a couple PMD committee members was to potentially look at having kind of an all-day special meeting for PMD and MDC within close proximity to each other to really try to do the entire set. Recognizing, however, that this is a volunteer body and that you are volunteering your time, but just trying to figure out how to do this in the most expeditious fashion. So that was one option that was put out there, but we did want to just talk about that and look and see what the groups were thoughts were. We can certainly keep back on the cycle, but I don't think we'll go back to doing kind of all the special meetings individually that we had, just because we found that while we reviewed quite a bit, once it got to MDC, there was too much kind of pushback of things we need to reassess PMD today. So I'll kind of kick kick off the conversation with that and get feedback from the group and thoughts on how you would like to proceed.
This is Jason. I actually really like that idea because it's a whole lot easier for me just to request one day off, get it all done, than multiple days where we spend a couple hours and trying to get all those days off with ED schedules.
I agree with that. I agree with that 100%.
Me too.
Is that you, Shari? I think I saw you unmute.
Might have been Amber.
Sorry, who is the last me too?
It's me. Sorry. Sorry.
Thank you, Shari. Any thoughts and other ideas? Like I said, I think the work that the committee has done, you guys do the lion's share of the preparation for MDC. MDC kind of then takes all of your work and they get to be the official approval body. But we certainly want to find a way to do this in the most expeditious fashion. And we recognize that all the special meetings that we've had didn't really result quite in the finished product that we're hoping for. So we'd love to get as good of a general consensus from this group as we could.
Hi, it's Brian.
So Gail, this is Franco. Would it be sort of like a retreat-based format, like just kind of get everybody sort of an 8 to 5 all day dedicated type of deal?
Yes, I mean, we still have to maintain the open meeting rules and requirements to make it available to anyone electronically. But the hope is that if we have kind of an all-day meeting, that we would have this in person with as many people as possible. And we'd certainly look to provide some refreshments as well, so make it worthwhile. But yes, that would be the goal, is to try to make it in a fashion that we can really knock it all out, as opposed to trying to do all these separate meetings. Because we have a lot of other topics. As you mentioned, and Sandy mentioned as well, you had submitted topics for discussion, I think, almost a year ago, and these kept getting pushed off due to the fact we couldn't get them on the agenda. So this would also allow us to hopefully cover other items a little bit more expeditiously too.
Yeah, this is Matt. I think that sounds like a really good idea.
Hi, it's Brian.
Go ahead, Brian.
So on some of these in the past, and let me ask a question first. So a number of these areas got assigned to people to look at, to make recommendations. And then that came straight back to PMD. There was no other work groups involved in that. Is that correct on the way this came about this time?
Yeah, people provided feedback in kind of a Google document that was available to the entire committee to review, and then it came to the committee to go through.
So in the past, we've had some assignments on different sections of these, and whoever was assigned to that looked at the national clinical model, and then they brought in recommendations, but it was handled in a work group to iron out a lot of these details before they got to PMD. For example, a number of areas that PMD were having to address were where the scope of practice is in different areas, and were they written for the right scope of practice? Because I know I made a number of comments on that. It seems to me like running this through a work group before having to have special meetings might speed that up, and then bring it back and do. It's fine to do the one session with PMD and MDC, but rather than addressing a lot of these other things that we were addressing at PMD, have that worked out before they get there.
So Brian, we did do that fashion, but that process still took about 2 years to get all of the guidelines through PMD. So even with having the work group, it still took from start to finish with the last update, almost a full 2-year cycle to get those all through PMD and MDC.
But part of that was at the time when the national clinical guidelines was coming out, and so there were huge differences and changes. I think that maybe that would be a little more streamlined when you are only going to look at ones. There may be ones you don't need to change at all. So I don't know. That's just a thought.
This is Jason. My concern, if you do that, it's just going to drag this on and on and on. I would still rather meet in a day, and if we have to say, okay, we're going to have a breakout session from our group and have several people working in small work groups, if we really need to, we can always do that. But I would, for my schedule, and I know for most of you, it's a lot easier just to say, I'm going to take this one day, it's dedicated, than to have lots of little meetings multiple times a month, month after month after month, and just it never getting done.
This is Erin O'Connor. I just curious for clarification, are we talking about the assignments would be made for the different sections? People would prepare in advance for that full day meeting by having already gone through and made their recommended changes based on evidence and any new data. And then once we hold the in-person meeting, it should just be kind of going through it and quickly. I guess before the meeting, the work would have been done before entering the meeting. Is that?
Correct. So, kind of, similar like what you did, you went through all the toxicology guidelines for this. What we found is that we're trying to get through such a large volume and limited PMD meetings that we're not quite getting through all of it in the detail that we need to, and MDC really pushed back quite a few at the last meeting. So the hope is that each person would do their comparison to the updated national guidelines, bring that to kind of the all-day session, and then we would highlight, go through those, and then hopefully get, if PMD were to agree to this process, see if MDC would agree to do something similar, kind of with the close proximity of the two meetings so that we don't have a loss of memory. I definitely feel like there was a lot of time between kind of our PMD discussion and the MDC meeting for some topics.
Yeah, I definitely agree. Like even today, we're supposed to go through the talk section, and I think you'll find that there's probably still some work to be done based on the feedback that's obtained from this group and this discussion before ever taking it to the MDC. So I think in a kind of a retreat-based, kind of get all of our ducks in order, make sure we all are in uniform agreement, and have it kind of really, I guess, ready for prime time would be ideal.
Gail, this is Franco. A follow-up to Erin's comments would be what I keep hearing this concept where, PMD would sort of do its work, but then there has to be, as you phrased, a close proximity to MDC, but then there's still one more loop of communication. MDC then has a send back opportunity, but then PMD still has another deliverable that needs to happen after that. So to me, it's starting to look like two individual segments of communication: a deliver, a return, and then another deliver and a final. How would that be baked into what you're proposing?
I mean, depending on the people's schedules, because we recognize most people have probably already submitted their clinical schedules for the first quarter of the year. So we understand that we want to make sure you people ample time frame to get that on their calendars. But I think there's a lot of crossover between PMD and MDC members. I think if we can have really good participation and kind of, in the past, if we've put together a pretty finished product to MDC, the feedback back to MDC has been pretty minimal. I see Josh, you're saying it's hard to hear me now. Is it any better?
Not quite.
The volume, it's just like you're way away from the microphone. That's all. Maybe move a little closer to the microphone.
All right, I'm going to try to scoot underneath. So in regards to your question about the time frame, I think if we could create something, we'd obviously need to give people ample time frame to get an entire day on their schedule. The goal would be to try to have something put together by PMD that is very finished, and that if MDC had any items to kick back to PMD, that those would be pretty minimal, hopefully. I think the feedback from MDC this time is much larger than we've seen in the past. Hopefully you're able to hear that.
Yes, thank you. Much better. Yes, so from my individual point, this format does sound superior, and I would support as well.
Yeah, this is Jason again. And I think even if we have some feedback from MDC, after we've done a full day thing, honestly, since I'm on NDC too, and with a lot of you already are too, is that we could come back and do, even if we had to do a virtual meeting to hash out if there was a few minor changes, and that would be a whole lot easier to schedule, but just getting the bulk of it done all in one day, I think would be very, very beneficial.
Well, this isn't a voting item, but rather just a discussion. Gail, anything else to wrap up the topic?
No, thank you. I just wanted to make sure, we certainly didn't want to propose something if the committee looked at us and what you're asking us to do, what, and we're kind of not in favor of that. So unless there's anyone who's really against that, please feel free to speak up. Like I said, we really want to make sure that we can hopefully make this as streamlined as possible. My next question would be, does the committee want to look, if they do want a one-day, would you want to push this into April, or do you still think you could potentially schedule something in first quarter with your clinical schedules?
I think I could probably switch a shift around. I don't think it's going to be that big a deal for just one day.
If you can,
Yeah, I can certainly,
potential dates. I was going to say, the sooner you get us the dates, I think the first quarter becomes possible. If it pushes for 2 more weeks or into December, it would be very hard to do it in first quarter.
Right.
Agreed.
Excellent, thank you. We will look for potentially a date in February then, as the NAMSP conference is in January, so I'm sure everyone's schedule that month is already pretty tight.
All right, thank you very much for bringing that forward. It's definitely a recurring theme for those of us who work on several different committees that require a rolling clinical guideline edits and refinement, that this is very time intensive. It's very important with regard to patient safety. It's very important with regard to frontline provider feedback. And this is as pre-hospital care becomes more and more complex, this becomes a bigger and bigger task. And I feel like at some point in the future, organizations and communities are going to have to look at probably assigning these tasks to specific personnel with much more protected time to do this work. Item K, discuss, amend, and approve T3G updates. We'll start with the toxicology section. Dr. O'Connor, if we can get a motion, please, first.
So moved. This is Matt.
Matt, thank you. Can I get a second?
Brian.
Thank you, Brian. Dr. Connor, take it away.
Yeah, thank you. So, and I guess to just put this in context, given the previous discussion, certainly there are many comments and items for discussion for more group input. And I will say, when looking at the kind of national guidelines, there are some differences in our current guidelines, and I wasn't sure how much to bring those kind of into the same format or fully replicate them. So I guess we can just, and again, when I first started this process, I thought I was just to make comments off on the side, and then I realized maybe just going ahead and changing some things was more prudent. So I've got a little bit of mix of everything in here. So we can just kind of go through the first one and get your input and impressions.
Dr. O'Connor, before you continue, Dr. Gaither, did you have a comment or question?
Yeah, it was mostly a question. I think we just discussed moving this work to a dedicated single day venue. My question is, do we want to table this until that dedicated single day? I, for one, probably won't remember this discussion in February. So maybe this is something we table and tackle in February.
Dr. Bradley, does that fit with your vision of what you were discussing, or do we need to push forward today to get as much approval as possible in the meantime?
You know, really that's up for this group's discussion and thoughts. You know, I think that the institutional lack of recall, I think, hits most of us at MDC because of the time frame between the meetings, just the way they are naturally scheduled. And so that was one of the issues that we ran into.
I'll make a motion then
As
to
of
table
now,
this
and
unless-
again, this is my own institutional recall problem, but are we not under a deadline at the moment for the new year to get as much of this content approved as possible?
We did not approve a single guideline at MDC the last meeting.
Okay.
So nothing will be approved by the end of this calendar year. So for entities that try to use these for their annual updates, that was one of the marks we did not get close to hitting because nothing did get approved at MDC.
Okay, so that's a no on that then. In my opinion, if we're not under any type of end of year deadline, then I would certainly agree with Dr. Gaither's comments that we go ahead and table until we have a future schedule organized. Does anybody have any other thoughts?
Jason, I agree with you. I think we should just wait and do it all at once.
Then if we don't have any specific objections in the room, Dr. O'Connor, my deepest apologies for you putting in the work and ready to present today. But I think we'll probably go ahead and ask for a move to table this and the other 3 items under this motion. Can we have a vote to table items? All those in favor of tabling, please say aye.
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 Any opposed to tabling? Any abstentions? All right, then the motion is tabled. Item 6 on the agenda, any agenda items considered for the next meeting, please remember to email those to Shelley. Her email address is listed on the agenda. And then the final item, or the next item, is a call to the public, please.
I've reached out to Kristen Britton and Sam. So please join.
Yeah, I'm here.
Oh, great.
Okay. Yeah, so I'm Kristen Bretton. I'm the Director of Public Health and Advocacy with US World Meds. Can you hear me okay?
Yes, ma'am.
Okay. And I just wanted to introduce, as the Director of Public Health, I'm just working across the country with all 50 states to introduce the education for ZIMHI, which is a 5 milligram naloxone prefilled device. So I simply wanted to make the information available. I have one slide I could share that tells the whole clinical picture, and I can speak to that just to keep it 2 minutes or less. Would that be all right to do?
Yes, I'll stop presenting.
Okay. I'm hoping you can see my screen. I think it's thinking.
Yep, we see it. Thank you. Go ahead.
Okay, thank you. Yeah, so just in the interest of keeping this short, I wanted to just show you, this is one page from our pamphlet that we have, but I'm happy to obviously share this in more detail with the PI because the PI is the FDA approved. But ZIMHI is it's represented as the red line on this chart, and it's the atom, and the naloxone plasma concentration is on the far left. So what you're looking at is that it's faster because it's a pre-filled injection, so it's IM delivery system. Plasma concentration level is going to get higher faster, so you're going to achieve that greater Cmax with the plasma concentration with the 5 milligrams, and of course it's going to be 100% bioavailable as opposed to intranasal delivery, and then it's going to last a little bit longer in the system, which can help when it comes time to the renarconization effect that can happen. So I'll stop sharing here, and we have the public interest pricing program. And we offer the public interest pricing program, so we have that available, but we have a big uptake across the country with law enforcement and interest in first responders just understanding leave behind programs, things of that nature. So I'll stop there just because I wanted to introduce it. I'm happy to answer any questions or email information to make it easier for you guys.
Thank you very much, Ms. Brenton, for that presentation and for the graphic to take a look at that. Is there a contact information you'd like to leave in the chat box, perhaps, before we conclude?
Sure, absolutely. I'll type it in there. Thank you.
Any further call to the public? Shelley, anything else from your end?
Not that I'm aware of.
Okay. Upcoming events, November 17th and 18th, the Arizona Trauma Association STACS conference. Actually, that's today and tomorrow. There's a second day also for that conference. It's over at the Monte Lucia here in Paradise Valley. December 8th, the AIMS third annual EMS CE Fall Forum, which is going to be held virtually. And then jumping into 2023, March 6th and 7th, the NAEMS Pediatric Symposium in Flagstaff. And June 29th and 30th, the Southwest Regional Trauma Conference down in Tucson. Our next meeting will be held March 16th, 2023 at 1200 hours. Otherwise, that is it for the agenda. May I have a motion to adjourn?
Ryan, so moved.
Have a second?
Second, Jason.
Thanks, Jason. That will adjourn the meeting. Thank you very much, everyone.